Hello friends, today's topic for discussion is anatomy of the thyroid as well as the parathyroid glands. This is Dr. Yusuf signing from Al University. So today's specific objectives on which the lecture is based are: the first one is describe the anatomy of the thyroid gland regarding its anatomical position, lobes and capsules, both the true as well as the false capsules. Then the relations, the blood supply as well as the lymphatic drainage of thyroid gland. The second is list the nerves which are in close relation to the thyroid gland and their clinical importance. The third is describe the development of the thyroid gland and list its anomalies. The fourth is describe the anatomy and development of the parathyroid gland. To begin with, this is the thyroid gland. This is how the thyroid gland will look like. And this is the position and this is the shape of this gland. This is called the thyroid gland. So as you know, the thyroid gland is a very important endocrine gland which is present in the body. This is present in the lower part of the front as well as the side of the neck, as you can see here. So this whole thing is the neck, and it is present in the lower part of the neck as well as even on the sides of the trachea. And it has many important functions. Some of them are: one is it regulates the basal metabolic rate, BMR, that is the basal metabolic rate. Then the second is it stimulates the somatic as well as the psychic growth. The third is it has a very important role in the maintenance of the calcium. Both the thyroid gland and the parathyroid together will be having a very important role in the calcium metabolism. This gland will have two lobes, as you can see here, one the right as well as the left lobe. There are two lobes. So this is the whole gland, and it has two lobes, the right and the left, and these two lobes are joined in the middle, in the front of the neck, by a structure called as isthmus. So isthmus, as the name indicates, isthmus means narrow part. So this is the narrow part of the gland which is connecting the right and the left lobe of the thyroid. So it has two lobes, the right and left lobe, and in between the part which is connecting the two lobes will be called as the isthmus. And sometimes there might be an additional lobe. This will be called as the pyramidal lobe. Okay, so if you can see here in this picture, they have shown the two lobes, and there is an additional extension from usually from the isthmus or partly from one of the lobes. So this will be a prolongation of this gland. This is called as the pyramidal lobe. This gland is in contact or in connection with the hyoid bone. If you can see, this is the hyoid bone here. Here on the top, just below the thyroid cartilage, will be the hyoid bone, and this hyoid bone will be in contact with the gland by a fibrous septum or band. This is called as the levator glandulae thyroidae. So if you can see here, it is called as the levator glandulae thyroidae, because whenever you swallow or deglutitate, at that time the thyroid the hyoid bone itself moves, as well as the thyroid cartilage moves. Along with that, even the gland will move upwards. Whenever you swallow, at that time it will be moving. So whenever the hyoid bone moves, even it will pull the thyroid gland. That's why it is called as the levator glandulae thyroidae. Okay, so this will be extending from the body of the hyoid bone up to the isthmus, or sometimes even to one of the lobes. Okay, so this is the fibrous or fibromuscular band. Coming to the situation and extent, it will be extending from the 5th to 7th cervical vertebrae, as well as up to the T1 vertebra, that is the first thoracic vertebra. You can question here, why C5, C6, C7, why not C8? Because as you know, there are only 7 cervical vertebrae, but when it is nerves, it can be C8. Okay, but here, because we are talking about the vertebrae, so there are only 7 cervical vertebrae, C5, C6, C7, as well as the T1. So these are the level at which this thyroid gland will be present, from C5 to T1. If you see the lobes of this, both the right and the left lobe will be covering partly the thyroid cartilage, which is above here. This is the thyroid cartilage. So it will be going up to the middle of the thyroid cartilage. It extends from the middle of the thyroid cartilage up to the 4th to 5th tracheal rings down. Okay, it extends from the mid of the thyroid cartilage up to the 4th to 5th rings. Okay, then the isthmus is slightly higher. It will be at the level of 2nd to 3rd tracheal ring. So these are the tracheal rings. These are the tracheal rings which are covering anterior as well lateral part of the trachea. So these are called as these are the cartilaginous rings which are covering the trachea. Okay. This gland extends from the middle of the thyroid cartilage up to the 4th to 5th tracheal ring, and the isthmus will be at the level of almost the 2nd or 3rd tracheal ring. If you see the dimensions of this gland, the total length will be almost 5 centimeters. It is a small gland. From one of the upper part of the lobe to the lower part of the lobe, this will be the total length, almost 5 centimeters, and almost 2.5 centimeters in breadth as well as 2.5 centimeters in thickness. This will be the dimensions of this each lobe of the gland. The isthmus is much more narrow, almost 1.2 to 1.5 centimeters in length as well as the breadth. Okay, so this will be the isthmus, almost 1 to 1.5 centimeters in length as well as in the breadth. Coming to the weight, it is a very small gland, as I said, almost 25 grams. And it will be much enlarged in case of the females, especially during menstruation as well as during pregnancy. Because during this period the gland will be highly secretory in function, so that's why it will be much more enlarged in case of the menstruation as well as during pregnancy. Coming to the capsules of the thyroid gland, the capsules of the gland are of two types. One is true capsule, which is nothing but the peripheral condensation of the whole of the gland, and false capsule is outside. It is nothing but the fascia, which is nothing but the extension of the pretracheal layer of deep cervical fascia. So true capsule is inside, deep inside. It is nothing but the peripheral condensation of the gland itself, and outside we have the pretracheal fascia, which is part of the deep cervical fascia, which will be covering even the thyroid gland itself. So that becomes the false capsule. And there is a plexus capillary plexus deep inside. This is called as the deep capillary plexus. It is deep to true capsule itself, so it is within the gland. So thus it is removed with the capsule during thyroidectomy. So whenever you do thyroidectomy, because it is deep inside the true capsule itself, so when you remove the gland, it will be removed along with the true capsule itself. But the false capsule is left behind because it is nothing but the modified deep fascia, which is part of the pretracheal fascia. So that will be left when you do the thyroidectomy. So you will be removing the gland along with the true capsule, and this deep capillary plexus is deep to the true capsule itself, so it will be removed along with the capillaries. Coming to the parts of the gland, as you know, it is made up of two lobes, the right and left lobe. If you see each lobe, it will be conical in shape, almost pyramidal or conical in shape, and has an apex. So this will be called as the apex. Then it will have a base. This will be called as the base of the each lobe. Then it will have three surfaces. One is the lateral surface, which is towards the skin, which is outside. This will be called a lateral surface. Then there is a medial surface, which is in contact with the thyroid cartilage as well as tracheal rings. Then there is one more surface behind, which is called as the posterolateral surface. So lateral surface is which is in contact with the skin and other structures outside. The medial surface, which is in contact with the tracheal rings as well as the thyroid cartilage, and posterolateral will be behind. Then it has two borders. One is the anterior border and the posterior border. Anterior border is here. This will be called as the anterior border. Then we have the posterior border behind. Okay, so there are two borders, anterior and posterior, and three surfaces, lateral, medial as well as posterolateral. Coming to the isthmus, this is about the each lobe. each lobe, right and left lobe. Coming to the isthmus, it has two surfaces. One is the anterior surface, which you are seeing right now, and the posterior surface will be in contact with the tracheal rings. Then there are two borders for this isthmus. Then one is the superior border as well as the inferior border. So two borders, superior and inferior, and two surfaces, anterior and posterior surface. Coming to the relations, as you know, it is just deep to the in the neck, deep to the skin, as well as superficial fascia and deep fascia. Then there is a subcutaneous muscle called as platysma, and just deep to that will be this gland. You can easily hold, especially when it is enlarged. You can, if you put your hand in the neck, in the lower part of the neck, you can hold the gland itself. So it is just deep to the skin, superficial fascia, deep fascia, and platysma. Okay, so those are the anterior relation. Coming to the posterior relation, as you have already seen, it will be in contact with the thyroid cartilage as well as the tracheal rings. Okay. Coming to the lateral relation, there are very important structures on the lateral side. One is the common carotid artery as well as its two divisions, the external as well as the internal carotid artery, as well as a vein, very important vein called as the internal jugular vein. So here you can see this is the thyroid gland seen from behind. This the picture seen from in the front, and beside that you can see this is the artery. This is the common carotid artery which divides into external and internal, as well as this is the internal jugular vein. Okay, so this is the anterior view, front view. This is the back view seen from behind, and you can see here the trachea with incomplete rings, and this is the trachealis muscle, which will be filling the incompleteness of the tracheal rings. Okay, coming to the arterial supply of this gland, it is supplied by two important arteries. One is the superior thyroid artery. If you can see here, this is the superior thyroid artery, and here also you can see here this is the superior thyroid artery, which is a branch from the external carotid artery. External carotid artery is the branch of the common carotid. Common carotid divides into external and internal, and external will give all the branches which are given in the neck as well as the face. The internal carotid artery doesn't give any branch here in the neck, but it will go deep inside. Then it will be giving branches inside the skull, especially it will be supplying the brain, main artery which supplies the brain. Okay, so the branches which are coming in the neck, any branches in the neck as well as the face are coming from the external carotid artery. So this superior thyroid artery is a branch from the external carotid artery, so it is coming from above, so that's why it is called a superior thyroid artery. Similarly, one more artery coming from below, this will be called as the inferior thyroid artery. If you can see here, this is the thyrocervical trunk, and from thyrocervical trunk there is a branch, this is called as the inferior thyroid artery. So superior thyroid artery coming from the external carotid artery, and inferior thyroid artery coming from the thyrocervical trunk, which is a branch again from the subclavian artery. Okay, then there can be sometimes an additional artery. Okay, usually it is supplied by only two arteries, superior and inferior thyroid arteries, but sometimes there can be an additional artery. This is called as the thyroidea imma artery. So sometimes there might be additional artery coming from the brachiocephalic trunk. Okay, brachiocephalic trunk, one artery directly from below. This will be called as the thyroidea imma artery. So this is the arterial supply of the gland, usually supplied by two arteries. Sometimes there can be additional artery. Coming to the venous drainage is drained by, this thyroid gland is drained by three veins. Even though it is supplied by two arteries, superior and inferior thyroid arteries, the venous drainage is by the superior, middle as well as inferior thyroid veins. Okay, so this is a typical feature. Even though it is supplied by two arteries, drained by three veins. Okay, the superior thyroid vein, if you can see here, this is the superior thyroid vein on either side. So this will be draining into the internal jugular vein. Then we have the middle thyroid vein, which is also draining into the internal jugular. This is the internal jugular vein on either side. Then we have the inferior thyroid vein, which forms a plexus. If you can see here, many smaller arteries join together to form the inferior thyroid artery, and it will be draining directly into the left brachiocephalic vein. Okay, so this is the left brachiocephalic, this is the right brachiocephalic vein, which together join to form the superior vena cava. So this is the inferior thyroid vein, which is draining into the left brachiocephalic vein and finally drains into the superior vena cava. Okay, so these are the three veins which will be draining the thyroid gland. Okay, sometimes just like the artery, sometimes there can be additional vein. This is called as the fourth thyroid vein, or it is also called as the vein of Cocker. Okay, so this will be draining into the internal jugular vein. Internal jugular vein. So the vein of Cocker can be drained sometimes into the internal jugular vein. This is an additional vein which can be present sometimes. Okay. Coming to the nerve supply. Nerve supply is mainly by the middle cervical ganglion. The sympathetic mainly is from the middle cervical ganglion. Sometimes it can be also supplied by the small contribution from the superior as well as the inferior cervical ganglions. As you know, in the neck there are three cervical ganglions, sympathetic, that is the superior, middle as well as the inferior. So this is mainly supplied by the middle. Sometimes it is also supplied by the superior and inferior cervical ganglions of the sympathetic system. So here you can see here, so again once again you can see this is the superior thyroid artery coming from the external carotid artery. Then we have the inferior, which cannot be seen here clearly. Then also you can see here, this is the superior thyroid vein. So this is the middle thyroid vein as well as this is the inferior thyroid vein. Okay. Now coming to the nerve supply or the nerve relations. We have already seen the nerve supply. Now the nerves which are very close to the thyroid gland, especially for the surgeons, it is very important because there are very important nerves which are beside this gland. So when you are doing thyroidectomy, you should be very careful. So which are these nerves? One is the first one is the external branch of the superior laryngeal nerve. Superior laryngeal nerve is a branch again from the vagus nerve. It is a branch from the vagus nerve. So this is the superior laryngeal nerve. It divides into the external laryngeal as well as the internal laryngeal. So external laryngeal will be supplying one of the glands of the one of the muscles of the larynx, that is the cricothyroid. Okay. Then there is second nerve which is in very close relation and very important. This is the recurrent laryngeal nerve. So there is also a branch from the vagus. There is the vagus here which is giving a branch here. This is the superior laryngeal which divides into external and internal, and the below it descend downwards, and then it gives one more branch. This is called as recurrent laryngeal nerve. Okay, so this recurrent laryngeal nerve is very important because it will be supplying almost all of the muscles of the larynx except the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. So it will be supplying all the muscles of the larynx as well as even the mucous membrane, that is sensory part below the vocal folds. Okay, so that's why these two nerves are very important, and these are in close relation to the thyroid gland. So the surgeon should be very careful, especially when he is doing some surgeries on the thyroid gland. So as I said before, both these are the branches from the vagus nerve. So what is the clinical significance? One is the damage to these nerves. Damage whenever you are doing surgeries, even compression of these nerves or damage to these nerves leads to disability in phonation as well as difficulty in breathing, because it will be supplying the larynx. So that is, the larynx is the voice box, so it will be disturb the phonation, as well as even because it is part of the respiratory tract. So that's why it also leads to difficulty in breathing, because the vocal folds are open and closed by these muscles of the larynx. So injury to the external branch of the superior laryngeal, the first nerve, injury to that external branch of superior laryngeal nerve leads to difficulty in singing as well as projection of the voice. This is, as I said, because it will be supplying a muscle, one muscle, that is the cricothyroid muscle, and this muscle is a very important muscle in case of the phonation and singing. So that will be disturbed. If there is injury to the recurrent laryngeal, this becomes more complicated because it will be supplying all the muscles except the cricothyroid. All other muscles of the larynx are supplied by the recurrent laryngeal nerve. So injury to one side of the recurrent laryngeal nerve will lead to hoarseness of voice because the other side is still intact. So there will be production of voice still, but there will be hoarseness of voice, as well as there can be aspiration. of foreign particles as well as even difficulty in breathing, okay, because of the non-functioning of one side of the muscles. Okay, if the injury is on both the side, then it is a very difficult situation, because the larynx itself is not functioning now, because all the muscles except the cricothyroid are damaged, they are paralyzed. So that becomes serious, and that leads the necessity of doing tracheostomy, where they put a tube so that for respiration. Okay, so this is injury to the recurrent laryngeal nerve if it is bilateral. Okay, then you have to do tracheostomy to keep the person alive. Okay, because it will injure all the muscles of the larynx except cricothyroid. Okay, so that's the importance of the nerves which are beside the thyroid gland. So when you are doing the thyroidectomy, should be very careful about these two nerves, especially the recurrent laryngeal nerve. Okay, now coming to the development, just a brief introduction to the development. In more details we'll study when we study the development as a separate chapter. Okay, here just a brief introduction to the development of the thyroid gland. So it will be the development of this thyroid gland as well as the thyroglossal duct is it begins from a structure called as foramen cecum, which is present in the tongue. So this foramen cecum is a small foramen which can be seen at the junction between the anterior two-thirds as well as posterior one-third of the tongue at the center. Okay, so this from here there will be development of a duct. This is called as the thyroglossal duct, and this will descend downwards from the tongue or the oral cavity down into the neck, and this will be descending into the neck and then helps in the development of the lateral lobes, along with contribution from the fourth pharyngeal pouch. If you see here, so this is, if you imagine, this is the foramen cecum, and from there a thyroglossal duct will develop, and then it leads to development of the thyroid gland along with the contribution from the fourth pharyngeal pouch. Okay, from where even the para-thyroid gland will be developing. Okay, so this will be from the thyroglossal duct. So this thyroglossal duct is important because this usually disappears, and just a remnant will be thin fibrous band will remain, but sometimes this can be patent. Okay, then that leads to complication. Okay, so just remember right now that it develops from the foramen cecum, where from where a duct develops and descends downwards into the neck, which is called as the thyroglossal duct, along with the contribution from the fourth pharyngeal pouch. Okay, so because it develops from the foramen cecum, sometimes there will be no descent. So this might lead to development of the thyroid gland within the mouth itself in the oral cavity. So here you can see here the development of the thyroid gland. This is called an undescended thyroid, or it is also called as the lingual thyroid, because it is present in the neck itself at the junction between the anterior two-thirds and posterior one-third. You can see the development of the thyroid gland itself. This is called as lingual thyroid if it doesn't descend into the neck. Okay, now coming to the structure and function of the this gland, that is the thyroid gland. In case of structure, this gland is made up of two types of cells. One are called as the follicular cells, and the second is the parafollicular cells. If you can see in this picture, so this is the follicle, and the follicle is lined by cuboidal cells here. These are called as the follicular cells. Okay, so these are the follicular cells, and beside that, outside the basement membrane, we can see parafollicular cells. So these are also called as C cells. So follicular cells as well as the parafollicular cells or C cells. Okay, so in case of the follicular cells, they will be secreting the T3 as well as the T4, which helps in the stimulation as well as maintenance of the basal metabolic rate. Okay, and the parafollicular cells will be secreting a very important hormone called as the thyrocalcium, and this helps in the deposition of the calcium within the skeletal muscle as well as other tissues. So when there is deposition of all the calcium which is present in the blood, that leads to a condition called as hypocalcemia, because there will be deficiency of calcium within the blood itself. Okay, so this will be just opposite to the function of the parathyroid. So the thyroid gland as well as the parathyroid with their secretions will be regulating the level of calcium within the blood. Okay, so the parafollicular cells will be secreting the thyrocalcium, which will lead to hypocalcemia. If there is excessive secretion of thyrocalcium, then it leads to hypocalcemia. Okay, and the follicular cells will be secreting the T3 and T4. So this is how these follicles will look like. So these are the follicles and these are the follicular cells, and between there will be parafollicular cells. So this is called as the colloid, and within the colloid there will be thyroglobulin. Okay, and it is because these are the hormones secreted here, so it will be highly vascular. Coming to the applied aspects, the most commonest as well as most important will be enlargement of the thyroid gland, that is called as goiter. So this is how it looks like. When it is enlarged, then it looks like this, and this is called as the goiter. Okay, so especially you have to do thyroidectomy whenever there is thyrotoxicosis, hypothyroidism. Okay, so whenever there is the thyrotoxicosis, then you are supposed to do the thyroidectomy. And if there is hypothyroidism, then it leads to cretinism in case of the infants. So those infants will be called as cretins. Okay, so it leads to cretinism in case of the infants, and in case of the adults it leads to myxedema. In case of if there is deficiency of the secretion from the thyroid, that is called as the hypothyroidism, then it leads to cretinism in case of the infants, where there will be incomplete development of the infants, and in case of the adult it leads to myxedema. And if there is enlargement of the goiter of the thyroid gland, especially because of the tumors, then it leads to severe compression, especially whenever there is enlargement of the gland like this, then it leads to compression of all the structures which are deep inside. Which are the structures which are deep inside? One is the trachea, then the esophagus, as well as the blood vessels are there. So all this will be compressed, as well as even they will be displaced, because this will be occupying. Neck doesn't have any space, so this will be occupying most of the area, and they will push the other structures deep inside as well as sidewards. These are some of the pictures which I have taken from the net, and the artist has very well depicted how the hypothyroidism or the low thyroid will not be identified by the missed by the doctors. Okay, so the best way of prevention of the low thyroid or the hypothyroidism is the knowledge. Now coming to the parathyroid gland. The parathyroid is a very important gland which is present behind the thyroid lobes. Okay, it will be a pair. One is superior and one will be inferior. This is the picture seen from behind. When you see from behind, then you can identify. You have to reflect the or remove the thyroid gland to see the parathyroid. So because they are present behind. Okay, so there will be one superior, one inferior. So a pair of superior as well as a pair of inferior parathyroid glands, which are very small endocrine glands, which will be present in the posterior border of the thyroid lobes. Okay, and within the thyroid capsule itself. So they will be deep embedded deep inside the tissue of the thyroid gland itself, and in the posterior border of each lobe. Okay, so that's why you have to see it from behind or reflect the thyroid gland and remove the thyroid gland, and then see on the posterior border. As you have seen, there is an anterior border as well as the posterior border for each lobe, and this will be present on the posterior border. So these are small yellowish glands which can be seen on the posterior border of the thyroid gland. The shape of this gland is oval or sometimes even lentiform. Small glands, very small, of the size of only 6 millimeters into 4 millimeters into 2 millimeters. That is, the length of this gland is just 6 millimeters, the breadth is 4 millimeters, and the thickness is almost 2 millimeters. So very small, size of split pea. Okay, so these are the parathyroid glands. Even though they are very small, but they have very important function. The weight is almost 50 milligrams. Coming to the position, the superior parathyroid will be present on the middle of the posterior border of the lobe. If you can see here, this is the one of the lobes, and it will be present on the posterior border. This is the posterior border, and in the middle part of the posterior border, it is not on the top of the posterior border, it will be the middle of the posterior border of the right and left lobe. But the inferior will be present below the inferior thyroid artery in the same posterior border, the lower part of the posterior border, just below the inferior thyroid artery. So this is the inferior thyroid artery. Just below that or beside that would be the inferior thyroid artery. Okay, so the superior will be present in the middle of the posterior border, and the inferior will be present in the lower part of the posterior border of the each lobe. Blood supply is by anastomosis of both these superior and inferior thyroid arteries. So these superior and inferior thyroid arteries will be anastomosing here in the posterior border, and they will then supply both the superior as well as the inferior parathyroid glands. So both the thyroid glands as well as the parathyroid glands are supplied by the same arteries, that is the superior and inferior thyroid artery, as well as the venous drainage is also similar to that of the thyroid gland, that is the superior, middle as well as the inferior thyroid veins. Even the nerve supply is also similar to that of the thyroid gland, that is, it will be mainly vasomotor nerves which will be coming from the middle cervical ganglia, just like that of the thyroid. Even this will be also supplied by the middle, as well as partly there will be contribution by the superior as well as the inferior cervical ganglion, mainly by the middle cervical ganglion. Now coming to the development is also from similar areas. One is the superior. There is some typical feature here. The superior parathyroid will be developing from the fourth pharyngeal pouch, if you can see here. So this is the fourth pharyngeal pouch, and this superior parathyroid will be developing from the fourth pharyngeal pouch. But the inferior parathyroid will be developing from the third pharyngeal pouch. Okay, it is supposed to be the third should develop from the third should give rise to the superior parathyroid, and the fourth should give rise to the inferior parathyroid. But it is reverse here. The fourth will be giving rise to the superior parathyroid, and the third pouch will be giving rise to the inferior parathyroid. So the parathyroid will descend downwards and goes all the way to the lower border, the posterior border of the lower part of the each lobe, and then from there it will be developed into the inferior parathyroid. So this is how it will be developing: superior parathyroid, endoderm of the fourth pharyngeal pouch, and the inferior parathyroid from the third pharyngeal pouch. Okay, so this inferior parathyroid is also called as the parathyroid 3. Okay, coming to the secretion, the most important secretion coming from this parathyroids will be called as the parathormone, which helps in the controls the metabolism of the calcium as well as even the phosphorus, along with the thyrocalcitonin, okay, which is secreted by the thyroid. So the parathormone as well as the thyrocalcitonin together will help in the control of the level of calcium as well as even the phosphorus in the blood. Okay, so the parathormone increase the calcium level, and the thyrocalcitonin decreases the the blood calcium level, because it helps in the deposition, and the parathyroid will be releasing more of the calcium into the blood, so there will be hypercalcemia. So the parathyroid activity is controlled by the blood calcium level. Mainly it is hormonal, and it is the level of this secretion of the parathormone depends on the level of calcium. If the calcium level is low in case of the blood, then it helps in stimulation of this parathormone secretion, and then there will be increased secretion of parathormone, which leads to increased level of the calcium itself in the blood. Okay. And if there is high level, that is the reverse of that will happen. If there is high level of the calcium level, then there will be inhibition of this gland as well as the secretion of the parathormone itself. Okay. Coming to the last part, that is the applied aspects. The first one is the tumors which are coming from the parathyroids. So if there are tumors within the parathyroid, then it leads to increased secretion of the parathormone. So this is called as the hyperparathyroidism. Hyperparathyroidism. So that will be the condition if there is some kind of tumors within the parathyroid gland. Okay. And if there is hypoparathyroidism, then this usually happens when you are removing the thyroid. If you are not careful and you are removing even the parathyroid, that leads to a condition called as tetany. If there is a decrease in the calcium level because you remove the parathyroid itself, especially when you're doing the thyroidectomy, so that leads to a condition called as tetany, where there will be decrease level of calcium within the blood, and that leads to some kind of seizures. Okay, so that condition is called as tetany. So this is all about the thyroid gland as well as the parathyroid glands. If you have any doubts, you can definitely write to me and I will try to answer. So these are my references, and the pictures are also taken from some of these textbooks as well as even from the internet. Thank you very much.